Good afternoon. We'd like to thank the organisers for allowing us the opportunity to present some of our findings on mental health service delivery within the public health sector in rural Zimbabwe. This work involved various players, including the Ministry of Health and Childcare, the Friendship Bench Harare team, and our team from SolidarMed Zimbabwe, represented by the names listed on this slide. My name is Janneke van Dijk and I work for SolidarMed Zimbabwe. This afternoon we will zoom into Zimbabwe, situated in southern Africa, with a population of about 15 million people. In 2020 there were reported 13 psychiatrists practicing in country. The number of clinical psychologists was around 126, and these would primarily be found in the larger cities. When we further zoom into our area of operations, we see that Masvingo Province has about 10% of the country's population. Whilst the second largest psychiatric hospital is within Masvingo Province, there is no psychiatrist posted there. We are aware of only one clinical psychologist being operational within the province, which is at this psychiatric hospital. SolidarMed is an organisation in health supporting the Ministry of Health and Childcare in the implementation of the National Health Strategy, with a focus on HIV and TB, maternal neonatal health, non-communicable diseases and digital health. The picture shows the 4 districts that SolidarMed is operational in, with Zaka district situated in the middle. To promote mental health care and relieve the strain on health facilities, SolidarMed Zimbabwe supported the rollout of the Friendship Bench initiative in Zaka district in Masvingo Province since 2019. The Friendship Bench is an intervention that deploys task shifting to address common mental disorders in Zimbabwe primary care. Community health workers, also known as lay health workers, are trained to provide basic cognitive behavioural therapy with an emphasis on problem-solving therapy. This task-shifting approach means we can deliver an effective, affordable and sustainable solution to bridge the mental health treatment gap at primary healthcare level. The trained lay healthcare workers deliver this talk therapy intervention to people with mild to moderate level common mental health disorders, such as anxiety and depression. In practical terms, participants are taught a structured approach to identifying problems and finding workable solutions. When people visit the health facility for any reason, they are invited to be screened with a locally validated tool called the Shona Symptom Questionnaire. If a person scores above the cut-off point, they are suggested to stay and receive the one-on-one problem-solving therapy on the Friendship Bench. From early 2019 onwards, 125 village health workers were trained, 5 for each of the 25 health facilities within the district. In Zimbabwe, women represent about 70% of the health and social sector workforce. Among the lay healthcare workers we trained, 74% were female. Over the whole period since February 2019, over 11,000 people were screened using the symptom questionnaire. Of these, over 3,500, which is 26%, were enrolled on the Friendship Bench. When looking at our context, rural women are more predisposed to experiencing common mental health disorders because of the patriarchal norms within families as well as gender inequalities. Women can be less likely than men to have power in decision-making. This also negatively affects their general needs and health. Disease outbreaks affect women and men differently, and epidemics make existing inequalities for women and girls and other marginalized groups worse. Also, the COVID-19 pandemic thrives on inequalities and inequities and has resulted in significant increase in gender-based violence, which was recently shown in a presentation from UNFPA, which reported a 40% increase of calls to the National GBV hotline during the year 2020. On a global level, the COVID-19 pandemic has undermined efforts to end gender-based violence through 2 pathways: reducing prevention and protection efforts, social services and care, and increasing the incidence of violence. For us to have a comprehension of the link between any form of abuse and the COVID-19 pandemic is important, in linking especially women in rural areas with the needed primary mental health services and building necessary support systems. Going back to our review, we looked at the data that was captured during the implementation of the Friendship Bench services, which was done at primary care and hospital level. Depressed patients often initially present with aches and pains. Nurses worked on the front line, were in general unsure how to make a diagnosis and focused on the physical presentation. Physical symptoms, though, especially those related to the heart and the head, can be cultural metaphors for fear or grief. For example, two prominent complaints, kufungisisa, or thinking too much, and moyo unorwatsa, a painful heavy heart, implied the carrying of an insoluble problem, and together seem to encapsulate the experience of depression. Once eligible for and interested in receiving further mental health support through the Friendship Bench, clients were asked about their problems and which ones they prefer to prioritize to discuss. We categorized the problems listed, sorting those related to emotional abuse, economic abuse, physical abuse, and sexual abuse. Besides the abuse categories, we identified 3 major other problem categories, which were related to family relationships, health, and poverty. This slide looks a bit more in detail at the abuse categories used, whereby emotional abuse can take a number of different forms, including accusations of cheating or other signs of jealousy and possessiveness. It can involve verbal abuse, deliberately trying to humiliate, isolate or ignore, and rejection. Withholding money, stealing money, and restricting the use of finances are some examples of economic or financial abuse. It includes behavior that denies a person economic or financial autonomy. Economic abuse often occurs in conjunction with other kinds of physical or emotional abuse. Physical abuse is an intentional act causing injury or trauma to another person by way of bodily contact. Sexual abuse is any unwanted sexual activity. For our review, we looked at a total of 8 sites. These included the 4 pilot sites where the Friendship Bench was first implemented within the district, and 4 sites that were included in an implementation research. Of note, 2 of the pilot sites were later also research sites. As you can see on this slide, training and implementation was done in batches of 5 health facilities. The 4 pilot sites included in this review all started providing services in February 2019. The other 4 sites commenced their services between July and November 2019. We first reviewed data from the 8 sites mentioned, where the Friendship Bench services were offered during the period between February 2019 and March 2021. These included 6 rural health centers and 2 hospitals, with a total of 160 months service provision. We looked at the problem list as presented by the clients during the lay counselling sessions and reviewed the prevalence of the various problem categories during the whole period. A total of over 6,500 patients were screened, with more than 2,000 patients, 32%, identified to have a common mental disease. For 1,841 participants, the problem list was available for review. Of those, 34% of the clients raised a problem in one of the 4 categories of abuse, ranging between 25 to 51% among the 8 different health facilities. Among the abuse categories, emotional abuse was the most frequent form of abuse, with 60%, followed by economic abuse, close to 27%, physical abuse and sexual abuse. Close to 80% of the clients enrolled on the Friendship Bench were female, with a slight higher proportion of females reporting abuse, ranging between 81.5% for abuse category 1 to 87.5% for abuse category 4. The following slides include different problems as they were shared by patients and listed by the lay healthcare workers. Within the emotional abuse category, there were problems related to rejection, harassment, infidelity, and accusations. In the abuse category 2, financial abuse, the following problems were listed. Husband does not give her money, but he wants to use her money if she does odd jobs. I want to kill myself because the man who impregnated me left for good, doesn't support a child at all. Husband does not care that I am ill and I do not have any financial support. Husband does now have another wife and is no longer looking after his child. Brother is taking away land. In abuse category 3, the following related problems were listed. Son abuses alcohol and substances, resulting in him physically beating his parents. Being beaten up by the husband when he comes back from drinking beer. My husband is harassing, beating me, and he continues to marry many wives. My husband is divorcing me and he beats me because he says I chased away another woman he was about to marry. Being beaten by my husband, claiming that the child is not his. Being beaten by the wife. In abuse category 4, sexual abuse, some of the problems listed were: husband does not want protected sex, yet his viral load is high. Raped by my grandmother's brother. For health-related problems, which came up after the abuse categories in frequency, the following were listed: trying to get a baby to no avail, ill health of self or family members, child disability, mental health issues, blindness and mother's illness and no money for medication, husband refusing to be tested for HIV, and stop taking ARVs because I'm in denial. Family-related problems were often misunderstanding and disagreements, conflicts with husbands-in-laws in the homestead, late husband's family, amongst children, stepmother, cousins or siblings. Some examples were: I had a child before I married my current husband, but now his relatives do not want us to live with my child. Conflict with my husband after insertion of Jadel family planning method. Some of the poverty-related problems listed were having no money for school fees, no money for advanced education, for medication, no money to start a project, thinking about hunger issues and troubled with school fees as my husband is dead. Husband family want to inherit me, but it is scary these days. Often there were multi-problems, and then the most severity was indicated. I'm ill, conflicts with my wife, destruction of my house, being unemployed, conflicts with my relatives. Another person had lack of resources to look after the orphan, conflicts with my husband, financial crisis, pain of heart, illness of my children, and my husband is misusing money, all in the same person. When looking at the possible impact of COVID-19 on the occurrence of abuse, we included the 4 pilot sites, where service provision started in February 2019. For these 4 sites, we could compare the 1-year periods of March 2019 up to February 2020 with March 2020 up to end of February 2021. The COVID pandemic reached Zimbabwe in March 2020, which was also the time when the first lockdowns were implemented. The 4 sites included 1 hospital and 3 rural health centers. This slide shows that there was a significant reduction in the number of people accessing care in 2020, while the overall proportion of females enrolled on the friendship bench stayed the same. If we look at and compare the problem listing between 2019 and 2020, we see that there was an overall increase in problems raised that fell within the abuse category. In 2019, about 30% of the problems presented could be categorized as abuse, whereas in 2020, this increased to 35.6%. Within the abuse categories, there was an increase in the proportion of physical abuse reported, whereby it seemed psychological abuse escalated to a next level. Of note, people who experience physical abuse often also experience psychological and economic abuse, and therefore the abuse category 3 does not exclude the existence of lower abuse categories in the same person, and does not necessarily mean a reduction in psychological abuse. We looked at the prevalence incidence of the different categories over the years, and gender of those presenting the problems listed. The red line in the bar graph shows the overall proportion of females enrolled, which was at 76%. The vertical bars show the proportion of females represented in the different problem categories by year. This has to be seen in relation to the actual numbers seen in the table, which greatly vary per category. In conclusion, our review showed us that problems related to any form of abuse was the most commonly mentioned among the problems listed. And during COVID, this proportion increased from an overall 30% to 36%. During COVID, there was a significant reduction in access to mental health care, and women more frequently visited the health facility to access care for themselves or their children, and therefore they were the majority of clients seen on the friendship bench. Therefore, the current format of service delivery allowed women to access mental health services. Men, though, may exhibit less health-seeking behavior, which can lead to a late detection and access to healthcare in general, including mental health. A different approach, possibly with a stronger community component, has to be considered to improve the utilization of available mental health services by men. Overall, combating abuse against women is of great importance and would need to include public education on gender relationships, increasing women's education and economic opportunities, and advocacy towards elimination of customary laws that sustain gender inequality. We thank you very much for your attention and we look forward to a further exchange of ideas and experiences.